We're going to see types of afferent arteries to AVM or arteriovenous malformation. So we have the transient artery, the bystander artery, terminal feeding artery, and the perforating artery. So the transient artery is just a artery that, let's say, this is the AVM. Here is happening all the connection with the vein or main venous drainage, the arteries. So let's say this is the nidus. We have afferent arteries, and they can be of these and choroidal arteries also. Choroidal feeding arteries. So we have these 5 subtypes. Let's say that we have a artery here that irrigates normal tissue, so gives branches to normal tissue, then sends branches to the AVM and continues to irrigate again normal tissue. So this is a transient artery. It gives supply to the AVM, but is not the main supply. These arteries arises in, for example, some insular branches of the MCA are very common to be transient arteries. The issue here is to preserve the normal branches and just cut the abnormal or the ones that are going to the AVM. We can recognize them because they are more dilated, tortuous, in compared to the normal branches, in comparison to the normal branches. Then we have the bystander artery. This is just a artery that passes near the AVM, but is not irrigating the AVM, so gives no branch to the AVM, just irrigate normal tissue. So usually here we just need to mobilize the artery. The ACA or branches of the ACA is a common bystander artery to a lateral frontal AVM, and the MCA is a common bystander artery of a medial frontal AVM. Then we have the terminal feeding arteries. These are the arteries that irrigate the AVM, so gives primary the supply of the AVM. They have large diameter, high shunts, high flow shunts. Both they are in this varinoid space, so it is easy to find them because they are superficial, and we can coagulate them, or in rare cases we can use a clip and then divide the artery. The perforating arteries, this gives also the supply to the AVM, but in contrast to the terminal feeding arteries, these perforating arteries are deep, so are in the ependymal layer. They go through white substance, white tracts, white eloquent areas, and they can irrigate the AVM. So because their wall is thin, they cannot be coagulated with the bipolar, so we need to use a microclip to occlude the artery. And the bleeding of the artery is very dangerous because the artery is irrigating deep part of the AVM. The diameter of the perforating artery is less than that of the terminal feeding artery. And lastly, we have the choroidal arteries. The choroidal arteries also irrigate the AVM, just the AVM that has ependymal extension to the ventricles. So we have three main choroidal arteries, that is the anterior choroidal artery and posterior medial and posterior lateral choroidal arteries. So the anterior one irrigates a temporal AVM, the posterior medial irrigates thalamic AVMs, and the posterolateral thalamic and atrial AVMs. So they're also deep. The bleeding is dangerous because they can fill the ventricle without being noticed, and they can produce herniation of the brain. They can be coagulated with the bipolar because their wall is larger than that of the perforating artery. And so the issue here is just to reduce the blood supply to the AVM, because like that it seems more like a cavernoma, and it is easy to then resect the needles. The terminal feeding artery and perforating artery are the main supply to the AVM, but this one can be dissected at the pia layer, and this one needs to be dissected in the ependymal layer or parenchymal layer, this with microclips, this with coagulation or clips. And bystander artery, we just need to avoid it. Transient artery, just to cut the small branches that are going to the AVM. And the choroidal artery with coagulation.